There are two major causes of maternal death. One is PPH, another is PIH. PIH is also, I found something new on this, which is really wonderful, working very well. So some part of it I have already explained in my previous presentation. The title of the present topic I am presenting is oral hydration therapy to prevent severe preeclampsia. Preeclampsia is a devastating human-specific disorder of pregnancy. As there is no other way than the allogenic fetus to grow inside the mother, the immunological interactions between maternal immune system and fetal proteins at uteroplacental bed, and also between deported fetal proteins and maternal immune system at different organ sites of the mother, are inevitable. For the same reason, preeclampsia cannot be preventable. Maternal immune system undergoes adaptive changes to accommodate the allogenic fetus. Preeclampsia results due to the failure of this accommodation mechanism at any stage of pregnancy. Immune maladaptation mechanisms results in excessive production of anti-angiogenic proteins like SFLT1 and soluble endoglin, which leads to endothelial dysfunction both at uteroplacental bed and also at different organ systems of the mother. There's uncontrolled predominance of anti-angiogenic factors in preeclampsia. Increasing levels of circulating SFLT1 is observed with the increasing severity of preeclampsia. SFLT1 induces preeclampsia-like phenotype in experimental models. Ravi Tadani et al. Reported extracorporeal removal of circulating SFLT1 by dextran sulfate apheresis reduces proteinuria and stabilizes blood pressure. By repeated dextran sulfate apheresis, they could continue pregnancies for a variable period of 1 to 3 weeks. SFLT1 is excreted in the urine to some quantities. Urinary and fractional excretion of SFLT1 is much higher among severe preeclamptic women when compared to mild preeclamptic and normal pregnant controls. In this preliminary study, we tested the hypothesis that consuming plenty of oral fluids and producing a targeted urine output of more than 2,500 ml in 24 hours may significantly reduce clinical symptoms and may also help to continue pregnancies to viability, as enhanced renal excretion of SFLT1 is possible. This is what we call as oral hydration therapy, or OHT. Coming to the methods, in this case control study, pregnancy outcomes of 20 singleton early preterm preeclamptic woman with hydration therapy. Early preterm means less than 34 weeks, and with hydration therapy, and were compared with 20 gestational age matched preeclamptic controls that were treated conventionally without hydration therapy. 20 cases we have treated with hydration therapy, and gestational age matched controls without hydration therapy, the results were compared. Hydration therapy. Women in cases group were advised to take plenty of oral fluids and produce a targeted urine output of more than 2,500 ml in 24 hours. Women were advised to pass urine into the given measuring jar and advised to measure the urine output at every voiding. Total urine output from 7 a.m. to 7 a.m. next day, that is 24 hours, were recorded. This is the urine output chart which I have developed. You can see here vertical columns are there. Date wise we put date here. Each digit on the column represent 100 ml. At every voiding, suppose the woman passes 300 ml, each digit 100 ml, 100, 200, 300, she marks here. Under 400 ml, next voiding, 100, 200, 300, 400, like this. Under voiding to 200 ml, 100, like that she went on marking like this from the morning 7 a.m. to next day morning 7 a.m. After completion of the day, he will color like this. Advantage with this is, at any given time of the day, she knows how much urine output she made, and also she plans how much water she should take to achieve the targeted urine output of more than 2,500 ml. And every visit she has to get this card, and the doctor signs it. For the doctor also, you can very clearly know and what day she has taken what, and whether she is following the advice of OHT properly or not, you can make an assessment. The complaints of the patient, we can easily make out and advise them to take necessary action. Another simple method, this is 3 liter bottle method. Here, we don't need to measure the urine output chart. This is for field work, like ANMs and ASHA workers. What they have to do is 3 liter bottles, 3 liter full water bottles should be given to the mother morning at 7 a.m. She has to finish this water by next day morning. The results are equally good. And what we do here, suppose we advise them in the antenatal checkup, you advise them to take plenty of oral fluids, and if there's clinical features of mild preeclampsia, we ask them to take 3 liters of water, more than 3 liters of water 24 hours. And suppose if you have a CMI, in spite of that, if the woman is developing mild clinical features of preeclampsia, then we keep them urine output chart and ask them to maintain the chart, and we monitor. Blood pressure was controlled with capsule nifedipine, tablet labetalol in adequate doses at required intervals in both cases and controls. Antenatal steroids were given whenever needed. Outcomes recorded were birth weights, development of RDS, NICU admission days, take-home baby at discharge were recorded in both cases and controls for comparison. Statistical comparison was done with independent sample t-test by SPSS 2007 software. Coming to the results, the mean daily urine output in OHT group was around 4 liters, and the mean gestational weeks that pregnancies could be continued were 7.51 weeks in OHT group and 1.39 weeks in non-OHT group. What I would like to say, OHT group, we could continue pregnancies to 7.5 weeks, and non-OHT group is only 1.39 weeks only. Such a difference is there. Maternal outcomes, mean arterial pressure that was observed in OHT group was 104 millimeters mercury, and non-OHT group it was 115. In non-OHT group, where she didn't take water, and the mean arterial pressure 115, which is very high when compared to 104. Urine albumin dipstick grade was 0.63 in OHT group, 2.15 in non-OHT group. Mean edema grade was 0.34 in OHT group, 1.37 in non-OHT group. You can see very statistically significant difference between these two groups. And neonatal outcomes, number of babies that developed RDS was only 1 in OHT group, 10 in non-OHT groups. Mean NICU admission days were 0 in OHT group and 8.36 days, 36 plus or minus 7 days in non-OHT group. And mean birth weight was 2.54 in OHT group and 1.68 in non-OHT group. What I'd like to say here, there's a gross difference between OHT group and non-OHT group. Number of women that developed eclampsia was 0 in OHT group and 4 in non-OHT group. Imminent eclampsia was 0 in OHT group and non-OHT group is 6. Severe PH was 0 in OHT group, 5 in non-OHT group. Take-home babies, number of mothers that took babies home was 19 in OHT group, 14 in non-OHT group, and number of intrauterine fetal deaths were 1 in OHT group, 6 in non-OHT group. When the woman is taking so much water, always we think the woman may go for electrolyte imbalance. We made a study on electrolytes. The mean serum sodium levels were 139 in OHT group, 138 in non-OHT group. Minimum serum potassium levels were 4.09 in OHT group, 3.97 in non-OHT group. More or less these values are same, and there is no statistically significant difference is there, and it shows that OHT do not produce electrolyte imbalance. Likely mechanism for oral hydration. How oral hydration therapy is able to control, prevent severe preeclampsia. Fluid continuously enter into vascular compartment from gastrointestinal tract. This increases blood volume and hemodilution. Increased blood volume, increased renal, uteroplacental, and other organ perfusions. This results in increased urine output, and which further results in increased excretion of antiangiogenic protein SFLT1. This leads to reduction in blood levels of SFLT1 and further reduction of endothelial dysfunction and clinical features of preeclampsia. By all these mechanisms, hydration therapy breaks the vicious cycle of pathophysiology of preeclampsia. This could be the reason for our excellent results. OHT could continue pregnancies for 7.51 weeks when compared to dextran sulfate apheresis could continue pregnancies 1.1 to 3 weeks. Dextran sulfate technique is very cumbersome, very costly, not within the reach of every parturient woman, every antenatal mother. And whereas OHT is so simple, it can be applied anywhere, even in a small village. Further research is needed with SFLT1 estimation to confirm our results by multicentric RCTs. I would like to show the compliance of the woman for OHT. What I did was for 1 year and fluid output charts I took and spread on the floor of my hospital, and I want to show what's the compliance of the woman for this OHT. So many mothers, every mother follows. OHT is superior to aspirin in preventing preeclampsia. Aspirin blocks the cyclooxygenase and prevent platelet adhesion and prevent blood clotting. This prevents hypercoagulability of blood of pregnancy, that is blood thinning effect of aspirin, which maintains the tissue perfusion. But unlike OHT, aspirin cannot improve blood volume. Aspirin cannot correct hemoconcentration. Aspirin cannot facilitate SFLT1 excretion by kidney. OHT attacks the fundamental and basic pathology of preeclampsia. For the same reason, OHT is superior to aspirin to prevent severe preeclampsia and eclampsia. Pilot study. In Chittoor district of Andhra Pradesh, under the care of district collector Mr. Pradyumna IAS, oral hydration therapy was introduced on 1st August 2018. All the medical officers were advised to recommend OHT to all women after 24 weeks of gestation. Field staff like ASHA workers and ANMs were assigned the job of oral hydration therapy. I have already shown this chart to you. You can see 2017-18, 16 maternal deaths were there. And after the OHT, this year, only 1 maternal death was there. See, 16 deaths have come down to 10, 10, 10, 4, 4, 3, 1. Now, slowly, this program was, now it has become a habit for all antenatal mothers to drink plenty of water in entire Chittoor district now. Now, that's the reason why 16 maternal deaths during 17-18 has come to 1 death. So, that is the power and efficacy of oral hydration therapy to prevent severe preeclampsia. 5 years deliveries means 67,000 deliveries, 60,000 deliveries every year. Around 3 lakh deliveries were studied here. This is a paper I published on oral hydration therapy, and on conclusion, OHT therapy is a simple, very effective and easy practicable intervention which costs nothing to the patient when compared to dextran sulfate apheresis. Take home message, 3 liter bottles, 3 liters bottles. Advise 3 liters of water to every antenatal mother after 24 weeks of gestation. No child should become motherless in this country. It is very much possible to achieve eclampsia-free India. Thank you. Jai Hind.
Yeah.
Thank you, Dr. Samarth. This was something very interesting and very simple to do. And you mean to say that all mothers have to be recommended, or who have those pre-eclampsia indices high in the first
only
trimester?
high risk women.
My suggestion is no. I say preeclampsia, there is severe preeclampsia, mild preeclampsia, no preeclampsia. What I say
nowadays we are doing that indices in the second and during the NTNB scan only.
No, hear me first. What my perception, I have written a review article on this on pathophysiology. If next time, if you give me an opportunity, I'll talk on pathophysiology of preeclampsia. I say preeclampsia is there because some amount of mismatching is always there with every fetus. Because all fetal tissues definitely, and some part of them, fetal proteins enter into maternal circulation. The maternal immune system invariably acts on that. Just like a graph.
Dr. Samrat, it will decrease the intrauterine growth retardation due to the PIH and this.
No, yes, what I say, your intrauterine growth retardation, your acute hepatic necrosis, and many things, they are related to PIH only.
Yeah,
what
and
I
the
suggest.
hypercoagulability.
Hypercoagulability, And
we give both the aspirin and the hydration therapy, it is better or
that I have not tried. I didn't try. I don't
I'm
want to
just
try. Can't say.
asking.
It is for you.
Because
Even
we are discussing this.
even peripartum cardiomyopathy is also because of preeclampsia related issue.
Yeah,
And
but sometimes the aspirin has the different role and the hydration have the different way of rolling. So if we want to be, because sometimes DIC you can't prevent with this only hydration therapy.
but
We
you
must
can't.
answer
What
the
I say, no, the preeclampsia itself will come down. The SFLT levels will come down. I'm
but
not
that-
saying it is. You can stop everything like big preeclampsia cannot be prevented. Only
Yeah.
severe preeclampsia and eclampsia can be prevented. You cannot complete, because you have to, allogenic fetus has to grow inside the mother.
Yeah.
Otherwise you cannot have human beings. If every fetus is rejected by maternal immune system, no baby survives. Every baby will go for abortion.
That is the another issues, the immunogenicity. You have mentioned about the immunogenicity of the babies and
Yes.
mother in this the ecosystem of both the mother and baby. But the role of the aspirin is different way. So we cannot
I told
only.
you, it blocks the cyclooxinase and it
Yeah.
prevents blood clotting mechanism.
Yeah, that's why I'm asking.
It has got a blood thinning effect.
Yeah.
If you want to use that, I don't have any objection.
Because that will increase definitely the circulations, and sometimes in the early, if you diagnose the sign.
But one thing I would like to say, we are using aspirin since more than 10-15 years. Where is the reduction in preeclampsia?
Not a reduction.
I mean, see, same thing I have
I
seen.
agree that even if we are using the reduce, we have not seen a drastic reduction in this.
Drastic reduction. But here
in spite of using even 150.
Yes, that's what I'm telling. We are simply, somebody is telling use aspirin, we are going on using. We are not applying. I'm not blaming anybody. But one thing, we should have our own minds. If RCOG says everybody will start giving 150 milligrams, RCOG says 75, everybody will give 75 milligrams.
Yeah.
That's what I'm telling.
Sir, I want to ask, the females usually complains of repeated urine going is the problem, sitting in the bathroom is a problem. So with 3 liters of fluid, practically, are they having any problems? Because with a 7-month, 8-month baby, they are like
no, for
having
the sake,
in periphery.
For the sake of baby, they don't mind doing anything, I tell you. Because we have
many times,
because
that
we
is a practical problem. Pankuni, you are absolutely right. That's a practical problem. In the villages, it is quite difficult, especially in the night time. If they are taking how can they move into for the bathroom and everywhere?
I tell you one thing here. I've been using OHT since more than 10 years. Nobody complained this.
Yes. That's what I'm asking, sir.
That is one thing. Nobody has complained.
Ready to do anything for their baby. For their baby,
they will do anything. Other thing,
anything.
most of the cases, first pregnancy lost due to PIH, second pregnancy lost to PIH, third pregnancy lost, fourth pregnancy we could make it. We could give them a live baby. Not only
that is why I asked that only in high risk patients, then it would be all right. Otherwise, to give 3 liters right from 24 weeks is going to be a little difficult.
No. I tell you one thing. I say preeclampsia is there with every patient. See, we are our understanding of the disease something not correct. I would like to say. Preeclampsia, some small pregnancy edema is there.
That allogenicity is always there.
Always there.
Yeah.
So that, in fact, I used to give only for patients with mild pedal edema, mild preeclampsia. Then I realized, then I started, now we don't have severe preeclampsia at all. I have not seen eclampsia for past 15 years. Not only here, I am a member in OB-GYN group, and I have shared these things to all groups, all members there. Most of the people are using, and they are sharing their information. It is, they say you can eradicate eclampsia. You can eradicate. They are commenting. So that is I am telling you, this is nothing very serious intervention. You can advise your patients and you can watch your results within 1 month time. Within a month time, you can know whether it is working there or not. Most of the people in Kerala, most of the people in Tamil Nadu, I club these 2 talks, cannula and OHT, in every talk, so that it will have a combined effect in reducing the maternal mortality.
Dr. Samrat, it is, but both are such a big cause of the maternal death in a country, and the way you explain both the things is so simple way. How
Yes,
to protect, that is a very important thing. I must congratulate you, because the people are so much scared about this, and government and everybody is after this in the national program, how to reduce the maternal mortality. And it is very simple way.
yes,
At the grassroots level, we can do easily. And the simple hydration therapy, we can prevent the pre-eclampsia. That is a big thing.
big thing.
So it is your observations, and we have to do. There's no harm in doing the hydration therapy and I think so. There's no
Antenatal mothers.
It's very
See,
practical
The
thing.
water is
I
great
tell you one
method.
thing.
Water
You see the South Indian MMR now.
Yeah.
Everywhere the drop is only because of OHT and the cannula.
Yeah.
It is not one country, one hospital, one district now. You see, last time MMR for Tamil Nadu was 50, 53 minutes. Next year, 1 year, 1.5 years back, I started this program. It will come down to, it will be reaching around 30, 35 now. And these two small interventions, you can do in North India. That's why I'm struggling now.
Yeah,
We want to do in North India.
Especially in Rajasthan, the maternal mortality rate is quite high. We must go for it.
Rajasthan, Bihar, Uttar Pradesh,
Yeah.
and Assam.
Bimari-
Assam is the one thing, number one.
Yeah.
200 MMR today, even 180, 190. And my request for you, you are there in the NARCHI, everything. I am ready to cooperate with any of the people. That's why the moment Pankuri asked me, immediately I said, I am there with you. I will be always
We
there.
are really
with you.
thankful to your commitment, everything for this wonderful cause. Really.
Wonderful talk.
Yeah. But Chatur, how far is your place from the Chittur where you have done this program? Na?
I am born and brought up in Andhra Pradesh, studied from Kurnool Medical College, married from Tamil Nadu. I made a hospital in Kerala.
Kerala. But you have done this project in which state? Chittur.
This project I did in Chittur district of Andhra Pradesh.
Chittur. It is very near to the Venkateshwar Mandir, this Tirupati
Yes.
Mandir, na?
Yes, Tirupati, next district is now, previously Tirupati was Chittur district only, they have made a different district now.
Yeah, so if I request for the darshan in the Tirupati, can you help us?
My daughter-in-law is a pediatric cardiologist, she is working there, I can help you.
Oh, wonderful. Thank you so much. Every year I am going to Tirupati.
Every year I'll ask her to help you.
Okay.
She has got some. She has got some 3-4 tokens with her. She can use
I
it.
know that it is Tirupati. It is in Tirupati district, so that's why I'm asking this question.
No, I can help you. You can ask me. Just call me. I'll tell you. I'll tell her, and she'll make all the arrangements to you.
Okay, wonderful. My pleasure. Thank you, Dr. Samrat, for wonderful talk.
It was lovely and very useful talks. Let's see, we can arrange talks for you or practical demonstrations also through video. I'll do it at my college level also.
Okay, you can do. Otherwise, see the program what I have done in Chittur now, same thing I want to copy paste everywhere. Actually, we did similar program at both the district, Bihar.
No, and Dr.
Bihar, we did one program.
Dr. Usha and Dr. Deepa, they will start this program in their medical college. Because I left the SMS Medical College, I am working in some corporate hospital, but they both are working in the medical college. So
Let them do.
They have the very vital role.
Yes, let them do and get the feedback. Let us give the feedback.
They will definitely play the vital role, and the main of the NARCHI is the National Association of Reproductive Child Health. So it will be the big mission for all of the our NARCHI people also. I request Dr. Usha and
I will add on to.
Yes, ma'am.
You can give some dissertations to some of your students also.
Of course, we have got the new batch and we can think about starting this in our OPD based practice. We can use
If
this.
you could
send me the.
You can do in
price.
OPD
What is the price of the cannula?
The cannula cost only 11,200 only. We are giving at a very subsidized price. We're not trying to make money out of this. We want.
Is there any specialized suction machine for this or any suction machine?
Even manual suction pump, it works.
No, could you please send me the details of the paper that you have published for these articles that you have published?
I will send. Around 30 dissertations are running now. 2-3 are completed on cannula and OHT also. Some 3-4. OHT also 4 dissertations are running now. I can give all. I got material now. And
if you could get the seed article,
I will definitely give you. You just send a message me address,
Okay.
and I'll send you material both for cannula and OHT. These two things you do, you will be doing the greatest job for the nation, I tell you.
Yeah.
You will be
I
doing the
would like to
greatest
add
job.
that whatever sir has told is freely available on YouTube on his channels. All application of cannula, removal of cannula, how can we prevent, how to face the difficulties, everything is nicely explained on YouTube through his
Pankaj,
channels.
so if you could just message me his number.
Yes, ma'am. He's
I would-
easily available. I have ordered
Somebody is
cannulas 2
available on the
years back.
cannula also. He's
No,
No, but
and
that is when
cannula
I
also I
buy
am
the
available.
cannula.
What else can
That
I
is
do?
if I buy the cannula.
I am available on my
1,000.
cannula itself.
Yeah.
No, but I was asking about the original articles, na?
Yes,
So
original
that is
articles I'll
after
give
I
you.
buy the cannula.
No,
Yeah,
whether you buy or not, it's a different story. That's a different story. Bother about.
I mean, Udaipur is
Our
Udaipur
entire
2,
nation.
3 dissertations are being done, completed with the thesis. Udaipur R&T Medical College, and they are all happy with the results. My friends are also there, so they are using it very nicely.
Udaipur, no?
Yeah.
Yes, they are using.
Yes,
They
sir.
have already completed dissertation, and there are more than 30
Cannulas are
dissertations are
available at
running. 30 dissertations are running on cannula and throughout the country now, and 3-4 dissertations are running on OHT. In the beginning, I'm more concentrated on cannula. Now I'm really seriously working on OHT because that is another important
and sir has
intervention.
told that
Tell me.
Sir has told that he is ready to come to medical colleges also to have this workshop. Or even if he is not able to come, he will guide from the webinar or online and get the workshop in motion.
I
It's
did
only
have.
the initial hitch. It's only the initial hitch. Once you come for the workshop and people start using it, I think
It will go.
then
It will, there won't be any stop.
Yeah.
There won't be any stop. I know that.
And Dr. Somebody is asked, Dr. Bhagat is asking to continue the OHT if blood pressure is reading are back to the normal.
No, you have to continue till delivery. Other thing I tell you, some patients postpartum pre-eclampsia is also there.
Okay.
Some patients after delivery also they have developed the clinical feature. Those people also respond very well for OHT, and the amount of antihypertensive dose also will come down. And I advise them to continue OHT for about 3-4 weeks after delivery also, because the SFLT1 has to go out.
Thank you, Dr. Samrat, for wonderful.
Thank you. Namaskar. Very nice. We had a nice
you want to say anything? Pankudi? Pankudi? You are muted, Pankudi. Pankudi, you are muted.
Thank you
I'm
very
so
much, Dr.
happy
Samrat.
that
It
you all
was
made the session very lively and interactive. And I think my goal is, I started the goal. Let the light begin to Rajasthan also, and many more female lives should be saved.
Sure.
Yes,
And doctors'
very
lives. And
practical
doctors'
thinker.
lives.
Yeah.
Thank you, Dr. Samrat.
No, today's importance is my talk is not clubbed with any other talks. There is nothing like hurry, because even the power cut is there also. Now everybody is waiting for that. And if there is a big list of speakers now, I can't afford to have a free talk like this. So other thing, I believe that you have understood both the topics in toto.
Yeah, in total way.
That's what I understand.
Actually, and everything.
Thank you very much for the opportunity. Nice time I
Thank
had
you,
with
Dr.
you.
Samrat. Thanks a lot. It was really an enlightening session. And Dr. Pankri, would you like to give vote of thanks to everyone?
Yeah, I would like to give vote of thanks for the speaker, Dr. Samarjam. He was ready on the first call that yes, I'm doing, and made all the arrangements with nicely. Thank you, Veena ma'am, for encouraging me. Thank you, Usha ma'am, for joining. And even you are in traffic and driving, you made everything so nicely and lively. Thank you, Clarinet people. You all arranged everything very nicely, and there was no technical glitch from any side. Thank you, this technical team also.
Thank you so much.
Thank you, Team NARCHI. Yeah.
Thank you very much, all of you, for giving a nice opportunity to spread this concept in North India. That's what my ultimate objective. You please, you are the stalwarts there. You are the stalwarts there in North India. You have to spread this, and all of you should speak on cannula, not me. My talking level is over. It is hand over to you. You should spread. You should spread this in North India. I think I can't say 100% people are educated with this session. At least at 5-6 people, you can open and talk like this. I don't mind sharing my presentation. You can talk in your sessions and try to enlighten people and use these techniques to prevent maternal deaths and bring down maternal mortality. Thank you very much. God bless you, all of you. Thank you.
Thank you.
Thank you very much.
Thank you so much, all of you.
Bye,
So,
Usha.
with all your permission, I'm closing the session here for today.
Yeah.
And looking forward to hosting you again. Thank you so
Thank you,
much.
thank you.
Thank you. Bye.
Thank you all. Bye.